Welcome everybody. Thank you for joining this webinar on managing melanoma during the COVID era. COVID-19 has affected the way we manage melanoma. We continue to treat our melanoma patients, but we've modified our protocols to keep patients and providers safe. As these standards evolve, perhaps you've talked to some of your colleagues across the country who are practicing maybe a little differently than you are. Tonight, we're going to discuss the interdisciplinary standards that we've implemented at Penn and in the community to improve the safety of our patients and providers. Our expert panel of dermatologists, surgeons, and oncologists will address questions from diagnosis to treatment. Let's start by introducing ourselves. My name is Chris Miller. I'm the director of the Penn Dermatology Oncology Center, and I specialize in Mohs micrographic surgery and complex reconstruction of special site melanomas on the head, neck, hands, and feet. Let's introduce the rest of our panelists. Emily, will you introduce yourself, please?
Sure. My name is Emily Chu. Thank you, Chris, for inviting me to be here today. I am a dermatologist and a dermatopathologist on the faculty at the University of Pennsylvania. I see patients within the pigmented lesion clinic. I also have an interest in seeing patients with genetic tumor syndromes.
Great. Roman.
Yes, thank you so much for inviting me. My name is Roman Bronfenbrener. I'm a clinical associate at Penn, where I see patients and I'm involved with some resident teaching, and I'm also in private practice out in Willow Grove in Pennsylvania. I did part of my residency training at Memorial Sloan Kettering, where I did a lot of dermoscopy and total body photography, and I guess my interest has grown from there, and I use some of the technologies we're going to talk about today to help manage melanoma patients in clinic.
Great. Joe.
Chris, thank you for the invite. I'm an associate professor. My practice is essentially Mohs surgery, complex reconstruction. I direct the derm surgical education for the residents and trainees that rotate through, and part of my practice also has a cosmetic element to it.
Great. Giorgos.
Thank you, Chris, for the invitation. I'm an associate professor of surgery, surgical oncologist with primary focus, clinical and research focus in melanoma. Like Emily and others, I'm also heavily involved with the PLG clinic at Penn.
Great. And Lynn.
Good evening, everyone. Thank you so much for joining us. My name is Lynn Schuchter. I'm a medical oncologist. I'm chief of Hem-Onc at the Abramson Cancer Center at Penn. And my focus is on treating patients with melanoma. It's fun to join my dermatology and surgical colleagues tonight. Thank you.
Great. Well, thank all of you for joining. We've got a diverse panel to answer a broad range of questions, and we have built in time for all of you registrants who are in the audience to ask questions. So please use the chat function or the Q&A function at the bottom of your screen, and we'll be monitoring your questions throughout the webinar and be happy to answer them. This webinar is being recorded, and it will be posted on the Abramson Cancer Penn website. So we will be able to address you'll be able to review these questions if there was something that you wanted to review, or if you wanted to share it with a friend. So let's start with some questions for our dermatopathologist and dermatologist, Emily Chu. So Emily, the COVID pandemic has forced most dermatologists to delay skin checks for patients at risk for melanoma. Tell us about what your concerns are for delayed melanoma screening.
So yeah, I think there are a number of concerns that all of us had in not having as much access to dermatology care during the shutdown period. One issue is that we know, our patients are able to identify lesions of concern on their skin, but I always worry about the spots that they're not identifying on their own. So a number of our patients will come in with spots of concern, but I think most dermatologists have encountered a scenario where you see a patient, they're worried about a lesion which may turn out to be benign, and then on the same visit, at the same time, you see another lesion on their skin that actually turns out to be a malignancy and possibly a melanoma. So the lack of access to our clinic during that time makes me worry that we did miss melanomas that might have come in without actually even being aware of it on the patient's chief complaint.
a lot of dermatologists are maybe struggling to find access to the backlog of patients. They're trying to social distance in their clinics, and they have a lot of patients that they're trying to get in at the same time. So do you have any ideas for how we might triage patients for screening during this time so that we make sure that the patients we're bringing in the clinic, we're really targeting the ones that are at highest risk for skin cancer?
Yeah, absolutely. I think this is something that all of us are, are trying to deal with, and it's certainly a little bit of a struggle as we try to catch up with the, the patient backlog that all of us have. But certainly, I think being flexible is key. Given the concerns over COVID, there's some variability in patient comfort with coming into the clinic. Some patients definitely want to come into clinic to be seen because they realize that their skin exams may be fairly challenging, and they feel much more comfortable being seen in person for an entire skin check. On the other hand, there's still a number of my patients who have some concern about coming into clinic because they're worried that potentially they could be exposed to COVID, although I think the risk of that is much less likely given the precautions that we're taking in our clinic now. But they feel more comfortable talking about lesions of concern that they have via telederm. I think telemedicine is certainly a pretty powerful way of screening some of the patient concerns. There are some limitations to the imaging ability that we have, but if patients are able to take clear photographs, certainly we can triage a bit based on lesions of concern. So for myself, I'm trying to manage this by seeing patients in person who I think are at higher risk, and those are typically patients who have a personal history of melanoma, patients who have difficult exams, so the patients who've had multiple primary melanomas in the past, the patients who have many atypical nevi, which can be hard to distinguish from melanomas, and also the patients who may just have a higher anxiety level, and they, which feel much more comfortable coming into the office. For the patients who, I think are able to monitor at home and are comfortable with telemedicine, then certainly I'm happy to look at lesions in that capacity, and then we can always decide later on if we want to bring them in.
Yeah, I think maybe you've given a hint that maybe you're talking to patients by phone, even if it's not for a telemedicine visit, to help them figure out how to manage this. We've talked to several of our friends in the community, and here at Penn, you have a unique perspective as a dermatopathologist, as a real barometer of what's happening in the community, because you guys read so many of the biopsies from the community. Can you tell us what you're seeing in your own practice? Are more dermatologists appear to be out doing biopsies? And then are you seeing a difference in what that biopsy mix looks like? Are you seeing a few more advanced cancers than you may have expected?
Absolutely. So I did actually run some numbers, and this is also done in conjunction with Karakousis in our group, who was looking at these too. But it looks like from the week of February 3rd, there are approximately 23 invasive melanomas and melanoma in situ diagnosed in our lab. And then the week of March 30th, which is the week after the shutdown was implemented, there were only 2 melanomas diagnosed, so 1 melanoma in situ and then 1 invasive melanoma. And then last week was the week of June 15th, so we had 21 total melanomas and melanoma in situ. So we're basically back to, obviously these are snapshots and every week is a little bit different, but it seems like we are sort of back to the pre-COVID number, more or less. To your point, whether we're seeing cancers that are more advanced presenting, it's a little bit hard to say so far just because we don't have enough numbers, but certainly, during the shutdown period, I think there were, anecdotally, there were a few patients that were being diagnosed with cancers that were a little bit more aggressive looking, because those are the patients who basically made it through triage to say, well, this person has to come into clinic to have a biopsy because it looked worrisome enough.
Yeah, well, that's great. Your experience is similar to a study that was done in England that showed that in the same time period before and after the lockdown, they continued to see their screening patients, and they saw the same number of melanomas. So there were fewer screenings happening in the community, and that dropped from 23 pre-COVID lockdown to 2 during the lockdown. Shows how important it is for us to continue screening patients and finding safe ways to do that. Well, you gave a nice segue, Emily, to Roman. You talked about how you've begun to use teledermatology in your practice. And Roman is working in the community, but he's also an expert in technology. So we wanted to get his take on how he's using teledermatology. So Roman, in the first weeks of the pandemic, the National Comprehensive Cancer Network issued short-term guidelines recommending telehealth evaluations of new patients and for follow-up visits. Not everybody was doing that, so all of a sudden it accelerated the use of telehealth, and I think almost all of us are using some version of it now. Can you tell us how you're using telehealth to screen and diagnose melanoma for your practice?
Sure, happy to talk about it. I think you talked about both screening and diagnosing, and I think it's very difficult to screen a melanoma patient the way Emily pointed out, because you can only find things that the patient is able to point out to you or that a patient's significant other is able to point out to you. I find telehealth is somewhat more useful for follow-ups after either a melanoma procedure, where you can check to make sure that everything looks okay. If someone has some kind of concern about the scar, it might be useful for that. But obviously you can't palpate anything. You're not going to feel a lymph node using teledermatology. But it is somewhat useful. You can get a review of systems and you can talk about how treatment is progressing. As far as monitoring some of these patients and like checking to see how they're doing, there is some utility in a person that would otherwise be coming in maybe 3 or 4 months for a lesion follow-up for short-term mole monitoring, to have a device that they could take home, like a dermatoscope. With a little bit of training, they would be able to follow it. Of course, that requires a good deal of training of both the patient, and that takes a lot of time from the clinic. But in the most motivated patients, especially if COVID is something that's going to be periodically resurging, where clinic might need to be canceled and people might need to be rescheduled, and that might be a direction that we go in for people that are otherwise very high risk.
Now, I found that teledermatology is really helpful when you have patients select an individual lesion that they're concerned about. But and if the photo quality is good, you can really decide, does the patient need to come in for a biopsy or not? But I've struggled to try to find a way to evaluate areas of the skin that the patient hasn't identified. Are you aware of some technology on the horizon where we would be able to evaluate a more complete skin exam remotely?
Yes, there will be technology on the horizon. I think there's some stuff now, but it's limited by the patient, really. I mean, you can have the most technologically advanced physician, but the patient would still have to be at home taking these pictures or using the technology and interfacing with it. So in the current state, with store and forward teledermatology, which is what you're describing, somebody taking a picture of a lesion, sending it to their dermatologist, and ideally that picture is in focus and, you know, plus or minus dermoscopy. A Cochrane review that was performed showed that less than 7% of malignant lesions were missed using this technology, which, you know, that's not a number most providers, I think, would feel comfortable about, knowing that, yeah, we're good about 93% of them, but 7% we might be missing. So in my experience, I like it a lot more for triage, like you mentioned, where you can look at something and feel pretty comfortable that it's a seborrheic keratosis or, you know, not a melanoma, and say, like, let's evaluate this later, because I think everybody has had the experience of thinking something is a seborrheic keratosis and then it comes back and it actually, you know, it was a verrucous melanoma or something like that. So I don't think that with teledermatology in its current state, at least with just clinical images, anybody's going to be necessarily super comfortable calling something and just saying that does not require any further follow-up. And also, like you said, people come in for one lesion. It turns out the melanoma is on the shoulder, but the seb-care was on the back. So in trying to evaluate patients with that, there's technologies that would use images taken in the office, like total body photographs taken, for example, with an iPad, that the patient also has access to. And the patient can then look or maybe have somebody help them and check to see if anything is new or has developed that's different. The other thing that's nice is one of the technologies, which is called Skin.io. When you take those photos in the office, those total body photos, there's a disc that's in every single photograph that's a standard size. And so that disc is standardized by the artificial intelligence so that every lesion on that patient can be measured because it's based relative on the size of the disc. So you might be able to look at something and say, wow, it has gotten this much bigger over time, because you can have a measurement of a lesion from the past. And I think that also helps relieve a lot of anxiety for patients who might find a mole that just looks funny, and then they'll go back in time and see that the size actually hasn't changed. And then I think somewhere down the road, there are also advances that are going to be made as far as automating this. Like there's a technology called Mole Safe, which is almost like a tanning bed type thing that you stand in that takes 3D photos of you. And then someone called a melanographer, which is somebody that's trained to recognize and image lesions, takes dermoscopy photos of many of them. But it's just not very practical for your average patient. That would still require a lot of interaction with another human being. So I'm not sure, that's any less risk than going into the dermatologist. And for MoleSafe, the closest one is in Freehold, New Jersey. So it's not particularly accessible.
Okay.
Skin.io and Derm Engine, which are two apps that are available, do allow you to take quote unquote total body photographs at home using some kind of guidance through the app. But again, it's not perfect. The image quality is highly dependent on the patients, obviously, and the person that's taking it for the patient. So that's kind of left to be seen where that's going to go.
Okay.
But I think the coolest and the last thing that I'll tell you about is something called Derm Drone, which they're looking at, which is actually like a miniature drone with a high-powered camera, which can take images going around the patient, which requires no one anywhere nearby, and can actually give you like a nice 3D image of someone that you can compare it to prior total body photographs or something like that. So I think down the road, a lot will be there. And now that this is thrust into the limelight, I think there's going to be a lot of, movement.
Thank you. You mentioned a couple proprietary products. So I just want to clarify for the audience, you have no conflicts of interest?
Yes, I have no conflicts of interest. I use some of them, but
that's good. One more important question, and then we'll move on to Dr. Sobanko. But teledermatology takes a lot of time still. So you actually see maybe the same amount or possibly fewer patients. Patients often get comfortable in their own environment, and it's difficult to cut off a conversation that you might be having with them. So reimbursement is definitely an issue because you're spending just as much time. Can you talk to us about the current and future state of reimbursement for teledermatology?
So it is currently in flux. There was a waiver granted in the early days of March that allowed for teledermatology services to be rendered essentially in any setting. So the patient could do it from their home. They didn't have to go to a special teledermatology center to get it done. But there was a lot of confusion because Medicare and private payers were on different tracks. And in the very beginning, like from March collections, there were some issues where payments weren't being processed correctly. However, I checked, and in May and June, seemingly, if you bill the level of office visit as you're supposed to for telederm, it does get reimbursed at the same rate as that in-person office visit. It's, I think, more difficult to get up to levels of coding that you would get to within an in-office visit, just because it's more difficult to conduct the same type of exam or to have this, similar type of interaction. But for the level of coding that you're billing, you should be receiving payment kind of commensurate with what you were making before. And in fact, a lot of the payers, even the private payers, have said that they have waived cost sharing. So a lot of these patients don't, in fact, have co-pays when they do teledermatology.
Yeah, great. Roman, thank you for that. And we look forward to you helping us advance that technology. We need better ways to use it in our clinic. So thank you for that. Let's move to Dr. Sobanko. Joe, you have an interesting perspective on this pandemic for two reasons. One, you've been continuing to treat these special site melanomas with Mohs surgery and reconstruction during the pandemic for the highest risk melanomas, and now you're back to treating them as you were pre-COVID era. But you were also the leading person in the entire health system. You called more than 1,000 patients who had COVID testing because the dermatology department called more than 27,000 people because we were responsible for telling the community what their COVID test results were. So you talked to more people who were tested for COVID than maybe anybody in the health system. Can you tell us what you learned from that? Because you started at the beginning of the pandemic and you observed it all the way until just a couple weeks ago. What are your thoughts about that from that experience?
My first thought is that it's remarkable what the health system did. They recognized how to play to everyone's strengths. And the calls that I made are essentially me recognizing that I would not be as helpful in the front line. So I tried to leverage what I could with counseling. I do think that Sarah Samimi, Misha Rosenbach, Nicholas Melanazar deserve a ton of credit with the number of calls that were done and all of the faculty. So I think that gave us a keen look at what was going on in the community. I can tell you from the phone calls that we made, especially during the spike, up to 15 to 20% of phone calls we were making were to triage patients that were positive. And we saw firsthand how indiscriminate the virus is. Patients that were affluent in Society Hill were pretty darn sick compared to, similarly sick to the migrant workers and the nursing homes that were being totally ravaged. So that was a stark look at what we were dealing with and what we have to face for the future. And it informed how we wanted to approach our skin cancer patients. So we looked at the last 2 weeks of March when we were not operating and said, who needs to be treated? Whose risks of cancer are going to exceed the risk of the virus? And try to handle that in a really thoughtful way to maintain the safety of our patients and maintain the safety of the staff. We were going based off of data at that point. The best data that we had was coming out of Wuhan. And so, in the past 2 months with our experience, I think we've learned a lot, and the benefit of this webinar where we can share our experience. But I think one of the scariest things was with the way in which the virus infects. The prior pandemics that we faced in the past 2 decades, patients were being infected from visibly infected folks. And the fact that up to 40 to 50% of folks who are being infected from people who are asymptomatic or pre-symptomatic is perplexing to someone in clinic who's seeing someone. And although they may not have a travel history right now and they don't have symptoms, they can still shed the virus. And you're most infectious one day before you exhibit symptoms. And I think that that information has informed how we approach care moving into the summer.
Yeah, and you led our own clinic's approach to implementing safety measures during COVID based on that experience, and out of a profound respect for how difficult it is to make sure you detect COVID by screening questions. So can you talk to us about the safety measures that you've helped us implement in the Mohs surgery clinic here for patients and for providers?
I think the health system needs to get credit for giving us daily updates on both the density of the virus, the infections that are coming in patient side, and then just strong communication across departments from the leadership that we have. We recognize that distancing, masking, decreasing the density, deep cleaning rooms, disinfecting surfaces, all of those things could contribute to flattening the curve and reducing the likelihood of infection. But I think the elephant in the room was we can do all of those things. Patients can have masks on, we can have masks on. But is there a risk where someone who has gone through our vetting of making sure that they haven't had a travel history, that in a place that was densely affected with the virus, making sure that they did not have a fever or any symptoms that would correlate with COVID symptoms, having their temperature checked upon coming to clinic, could they still potentially infect someone? And there was a point where I thought that there was still an answer to that was yes. At some point we pivoted where testing capacity was increased at Penn, and Sarah Samimi led our piloting committee within the department. And it was clear that the health system had the ability to help us test our surgery patients. And where Mohs, I think, is unique in how staff could be infected, the dose, duration, and proximity of a patient to someone is the direct relation of how likely you're going to get infected. And if we're doing surgery on the central face for a prolonged period of time to resect the cancer and do the reconstruction, we're at highest risk, perhaps not as high risk as someone who's doing an intubation, but that information sort of led us to lobby the system, and we were given permission to do pre-COVID, pre-surgery testing, where patients are swabbed 24 hours before surgery. And right now we're operating at a significantly reduced capacity, but we are seeing patients with higher risk cancers and slowly opening up to intermediate and lower risk cancers. But many of the tumors we face, even if it's a low risk patient, if that tumor is on the nose, lips, or eyes, staff and we are at risk. So that has led us to develop more confidence. It has led to staff feeling safer. And the psychosocial component of this virus cannot be underestimated. The anxiety, depression, sleep disorders, moral injury that folks on the front line and those on the back lines are experiencing needs to be appreciated. And I think the confidence we get with testing has added value to clinic.
Yeah, one of the lessons for me with this pandemic has been how fragile our existence is, because if you take out any link in the care process, front desk, medical assistants, nurses, doctors, if any of them feels unsafe and doesn't show up, the whole system breaks down. So the testing really helped to keep people confident. Did you have any stories of somebody that you detected? We
started our pilot program with about 20 tests per week in the beginning of May. And within the first 2 weeks, when we were diligent crunching the numbers, one of my patients did test positive. And our protocol is we want a test within 24 hours of the procedure, and the clinicians will call the patient the night before the surgery. And that gentleman did have a positive test, entirely asymptomatic. We delayed the surgery, which sort of reaffirmed, especially when the viral density is higher and the curve is higher, there was value there. What I did learn from that experience, though, is that we suggested the patient come back 3 weeks later and go through the same protocol. And if you look at the possibility of being infectious, if you're more than 28 days after development of symptoms or more than 28 days out from when you test positive, you really don't have an ability to infect someone. But that gentleman's second test did come back positive, and with an overabundance of caution, we delayed his surgery again, and eventually I helped him out just a couple weeks ago. He did have a third negative test, but what that has helped the health institution learn is that when we want to test patients and then when to retest and perhaps not retest someone, because if an outpatient has a positive test and they undergo their quarantining and they're 28 days out from that positive test, they don't need to be retested again, because the likelihood of reinfection or the likelihood of transmitting these dead viral particles into someone into developing an infection is slim to none.
Yeah, well, thank you. And the testing and like Tele Dermatology is an evolving realm for all of us to learn from. Giorgos, you want to move on to you? Joe's treating patients in the outpatient setting. Most of your surgeries are in the OR, and you guys have made a lot of changes in the OR too. Why don't we start by just having you let us know what kind of safety measures you guys have implemented in the operating room?
Yeah, thank you, Chris. So, if you take it back to the beginning of the pandemic, we were at a state where we didn't know if we could use, how many ORs we could use, if we could use ORs. There was a big question about ventilator usage and really trying to preserve every ventilator possible. And as a group, you recall, Chris, we came together as a melanoma program and tried to come up with measures of triaging patients to surgery and to procedures. So deferring lower risk lesions, squamous cell, basal cell cancers, and MIS, deferring those cases and trying to preferentially treat the more aggressive lesions. And so measures we took early on were trying to avoid taking patients to the operating room that didn't need to be performed in the operating room, like cutaneous invasive melanomas that could be done in the office. We moved those to the office setting early on. We were prepared to defer sentinel lymph node biopsy based on resource availability, but fortunately we never had to have that issue. And essentially throughout the pandemic, we were able to perform sentinel lymph node biopsy on appropriate patients. We feel that the sentinel lymph node biopsy procedure is an important prognostic and staging procedure that can help direct adjuvant therapy. In terms of measures that we've sort of instituted in the operating room. So first off, even in the clinic patients, I think Joe began to allude to some of these. We have survey questions and temperature screening in the intake process. In the operating room, initially we had COVID testing required within 48 hours of a procedure. That now has become 72 hours prior to the procedure, and many new testing centers have become available. In the operating room itself, we've instituted many measures and checks to ensure the safety of patients and the staff. During intubation, anesthesiologists are routinely wearing N95 masks. The surgeons are staying outside of the operating room during intubation, which are thought to be a higher time for aerosolization of the virus. And so that has continued. Inpatients, we still do not allow for visitation of inpatients in the postoperative recovery period, although now patient families are able to accompany their family member and wait in the waiting area during that time. So we've had a lot of protocols that have shifted. One other measure we've taken is a scoring system that was actually developed out of the University of Chicago, the MeNTS scoring system, which is a way to sort of prioritize patients for procedures. And there's three basic groups that are involved in this MeNTS scoring system. One deals with patient factors that may put them at higher risk for developing a COVID infection or having a negative sequelae if infected. So it looks at things like age, diabetes, hypertension, immunosuppression. Then there's disease factors. What factors are, how urgent is a patient's surgery? And that takes into account, is this something that could be delayed 2 weeks or 6 weeks? And then there's resource allocation component in that scoring system, which involves, is a patient likely to require intubation during the procedure? Is a patient likely to require an ICU stay post-procedure? And so that has actually helped guide, and as we've now come back in with surgeries, allowed prioritization of the surgeries. I could say now, fortunately, we're almost near full capacity pre-COVID era. I think the latest statistic I saw was that we're approximately 80–90% of pre-COVID volume. So we've quickly ramped up, and I can honestly, I think the health system has done a tremendous job to ensure the safety of patients as they get shuttled through the process, and the staff. And personally, I've been operating through the pandemic. I haven't had any patients test positive for COVID testing pre-procedurally, nor any patients while in-house develop a COVID infection as well. So, I think that's a real testament to how good the safeguards have been really in the health system. I think you're on mute, Chris.
Kurt, thank you. Sorry for that. I'll encourage the audience again, please submit questions via the Q&A or the chat function. Our panelists are scanning for questions, and we'll be happy to dedicate time to answer them. Giorgos, you're on the National Comprehensive Cancer Network panel for the guidelines of melanoma, which gives you a unique perspective on what how important guidelines are during the COVID era. And the NCCN published guidelines in the beginning of March that were very conservative. Do you think, how do you interpret the NCCN guidelines, and how do you weigh them against the local practice? And I put it in context for you, for us. I know that when New York was at the peak of its surge, I was watching the sidewalks empty and the testing tents go up right out in front of the hospital, because we were expecting the surge 2 weeks later. And thankfully, as you said, it never happened. So can you talk to us about how you weigh local factors with national factors to make decisions in hospitals?
Yeah, thank you, Chris. I mean, I think, look, this is a pandemic that's really been unprecedented in the modern era. And I think what we learned is that it's important to be nimble and be able to adapt to the rapidly changing situation. I think that's the key. And even as those initial temporary NCCN guidelines, not to be confused with the the more established guidelines, which really are based on the best level of evidence and are not affected. Even as those were developed, I think it was clear among the panelists that these were to be interpreted by the local issues at hand. And so while there was potential for deferring sentinel lymph node biopsy in patients that would otherwise be indicated for it, that was really meant in situations where OR resources and facilities would not allow or permit that to occur. So I think those transient guidelines really had to be looked at through the lens of the local situation. And it was understood that these were meant to be set up sort of like doomsday scenario. Like this is something that it wasn't clear, especially early in the pandemic, whether patients could get to the operating room at all. I think it's good that they were developed as very conservative measures to give guidelines to practitioners about what is reasonable given this unprecedented occurrence. But it was meant to be used in the context of a local situation. I think fortunately here in Philadelphia, we didn't see the cases that New York or Boston or some other areas saw in particular. So,
yeah. I want to follow up on one more question for you, Giorgos. You talked about the University of Chicago scoring system. MeNTS is the acronym for the scoring system, minimally invasive surgeries. But one of the motivations to have a scoring system was to try to offload some of the burden on triage from the doctor. Because you could imagine that if you're in a resource-limited situation and you chose to treat one person versus another, you would potentially be subject to biases that could be misinterpreted by other people. Have you guys maintained that system? Or since we've had available ORs, has that gone away?
It's a good question, Chris. We still have a MeNTS score, and every patient I put on the schedule, I give them a score. And fortunately, that has not been an issue in terms of having cutoffs of what scores allow patients to proceed to surgery because we have the OR capacity. But the plan is to continue this MeNTS scoring until we really feel we may be in clear waters for the short term. This was a tough time, Chris, with making decisions. I had several patients that had urgent issues, but still issues. Patients with symptomatic benign tumors that we deferred, and so these were tough conversations to have to patients.
Yeah.
So I think you're absolutely right. I think this scoring system helped to take off the angst and feeling that it's all the onus is on the clinician. I do say that I think it's great that the department and the health system really though put the clinician and the patient relationship first and foremost in the decision-making process and didn't mandate anything per se. It really relied on the expertise of the clinicians to help triage patients throughout the whole process. So,
great. Well, thank you for that. Lynn, we haven't forgotten about you. Lynn, you're taking care of the sickest cancer patients in the system, and the medications that you give can also mimic some of the symptoms of COVID. So some of the issues that you confronted are slightly different than ours, where we're taking care of lower acuity patients, or our focus is surgery. So can you just talk to us about how COVID has affected your decisions taking care of your metastatic melanoma patients?
Yeah, thanks, Chris. I will first make maybe some more general comments, which is that if in oncology, each disease team or each practice, had to make decisions about which treatments could be safely postponed, which patients with melanoma who were undergoing surveillance scans could have those postponed, and which patients really required face-to-face visits. So throughout the COVID pandemic, we in the Abramson Cancer Center have been, fully operational and seeing patients, which has been true for really medical oncology across the country. And so those patients who are on treatment, have continued to come in for treatment. And so it really required that each disease team, really thought carefully about, what surveillance could be postponed, what could we successfully convert to telehealth, which that's, the silver lining of the pandemic is how rapidly we've been able to implement telehealth across specialties, which has been terrific. Specifically in melanoma, and actually this concept was also true in other types of cancer, was whether we should, say for a patient with bulky stage 3 melanoma where somebody had enlarged lymph nodes, should we go ahead and give them neoadjuvant treatment and delay their surgery? Certainly this approach was seen in breast cancer and a lot of other approaches where we decided to give treatment up front and a little bit delay surgery, because a lot of the emphasis on creating surge capacity in the hospital was reducing elective surgery admissions and freeing up anesthesia and everything. So in melanoma, we certainly have been giving treatment throughout, and we had a particular concern about using PD-1, the checkpoint inhibitors like pembrolizumab and nivolumab in the setting of COVID-19. And so one of the big questions was, were we going to see adverse outcomes, more immune adverse events in patients with melanoma who were getting immunotherapy? Because as you all know, in the setting of a COVID SARS infection, it's this overwhelming inflammatory response, particularly in the lungs, that has caused the issues. It's, much more than the virus. And so early on, the data from China, there was a signal that yes, patients with advanced cancer and who were getting treatment had a worse outcome. But that very initial report only had about 3% cancer patients. And then reports came out from Italy that maybe patients on immunotherapy actually had a better outcome. And so, as you know, we use immunotherapy in melanoma and lung cancer and lots of different types of cancers. So one of the big things that we've been studying here and a consortium across the country is looking at this question. And what we can say so far is, number one, patients with advanced cancer who are getting treatment have a worse outcome from a COVID-19 infection. So patients with a poor performance status, regardless of the treatment that they're getting, they're in that very high risk category. So that actually has made us have even more urgent goals of care conversations and wishes about intubation, because we do know that that group of patients with really advanced cancer, especially on chemotherapy, have a very bad outcome. But we also learned that immunotherapy, just by itself, there is not a worse outcome. And so we have been super cautious, but we have not seen patients with more immune adverse events, and particularly no increased pneumonitis in patients with melanoma, either in the adjuvant setting or stage 4 disease, having a bad outcome. So we've been able, in melanoma and across all disease sites, continue immunotherapy and chemotherapy where appropriate. One particular regimen of ipi/nivo that we use mainly for stage 4 has a much higher risk of toxicity. If we just use single agent PD-1 antibody, there's a 20% risk of side effects, and they're still not significant, generally low grade. But when we use ipi/nivo, it's more like a 50% chance of adverse event. And those adverse events, those immune adverse events, colitis, hepatitis, etc., much higher grade. So we did limit ipi/nivo in some patients with stage 4 melanoma. So the patients that I would I did avoid it during the height of our COVID-19 in our region, or it was an elderly patient with ipi/nivo. But I have to say that a young patient with stage 4 melanoma, I continue to give ipi/nivo, because we never were in an ICU or inpatient bed crunch that I wouldn't be able to successfully, take care of that patient. Bigger pictures about patients undergoing bone marrow transplant, and we definitely had to make decisions about postponing. So I would say that, specifically in melanoma, we postponed a lot of surveillance scans. We've been doing telehealth, but some cancers, say lung cancer, GI cancers, the physical exam is not that important. But in breast cancer and in melanoma, where most of us are also doing skin exams, you do need to do a physical exam. So we have been bringing, more patients in for physical exams because we also want to feel lymph nodes. We want to, identify new melanomas or in transit metastasis. Actually, Emily and I just saw a patient who I thought a mole looked different. And I took a picture of the patient's mole. She had her photographs that were done before. She took a picture of her photo, sent it to me. There was a huge change. Emily got her right in, and she had a melanoma in sight too. So the exam matters. If I could just a few more things, sort of linking back to Joe. So our decision making about COVID testing is that we are not doing testing for patients undergoing treatment because these patients are getting treatment every 3 weeks. And so that would be a lot of testing. So we are not treating people with an active COVID infection. So they have an active infection. We are holding their treatment until they recover. And we have designated in our oncology areas, hot and cold areas. So patients that are, we're concerned could have COVID and have a fever, which, in cancer patients, this is a complicated, question about what is the fever from. But we have designated areas because we'd have asymptomatic testing for our elective admissions, symptomatic or PUIs, persons under investigation. So we have separate areas. And sometimes we have to treat a patient who's COVID positive, and we have designated units. Patients still may need transfusions, and they're COVID positive, and so we have designated areas. For radiation therapy, we are doing COVID-19 testing prior to any radiation therapy. As Giorgos mentioned, all of our surgical patients get COVID testing. And then, return to treatment is complicated for a patient who is COVID-19 positive. In immunocompromised patients, and these are some of, I see the names of the dermatologists on the call, you have patients who are immunocompromised, and live viral shedding has been shown to maybe be longer in immunocompromised patients. And so we use either a test-based strategy, 2 negative test, or symptom strategy, as Joe mentioned, that if you're a certain amount of days from symptoms, no fever, and the test is still positive, likely viral shedding and not true, we will return those patients to treatment, but we use full, PPE in caring for those patients and make an assumption that they're positive. And I'm going to use 30 more seconds of my time, if that's okay.
You got time.
I just wanted to say that, so we've been in clinic this whole time, and the staff have been accustomed to making these adjustments, and as we learn, and I won't go into it all now, but we feel really safe, and the data shows that when you're wearing goggles in a face-to-face situation, mask, gloves when you're examining patients, that the risk of transmission is really low. We've set up our exam rooms to be at a distance. But for people who haven't been here and have been home, either doing telehealth and are now coming back. So I see the names of the dermatologists here. I know that you've been like running into your office to get me a path report or urgently caring for a patient, but for a lot, you've been closed. I think it's really hard, for the staff to come back in. So, reassuring them and, setting up strict policies about visitors, social isolation, your visitor room is correct, you're wearing PPE, your patients are masked. We have a healthcare workers study here at Penn for people who are not in the COVID units, but I've taken care of patients who are COVID positive. There's over 2,000 healthcare workers enrolled in that study. Only 2% are positive for antibody. So people who have been here caring, we feel very protected by using the PPE that's been established. And I think that you can really safely care for your patients. And as we've talked about, really to prioritize those patients, that need to come in. you know, we are getting a little nervous about some of the patients that are coming in with more advanced symptomatic stage 4 melanoma than we probably would have expected, and we'll just have to see. So many patients have deferred their care during this time. So I'm thrilled to see our derm colleagues, you know, back in, but I know it's really stressful for your team and for you, but I do think it can be done in a really safe way.
Absolutely. Thank you for those comments. Can you give us a sense of what the census is like in the hot and cold units? Have the hot units, has the census fluctuated in the hot units?
Well, you know, I have to say that for our oncology patients, we have seen a very low incidence of COVID-19 infection. And that's because we certainly have been instructing patients, and we know that they're at higher risk. People are, you know, in their community masking and wearing gloves. And so, yes, it's still been very low incidence. In the hospital, you know, today at HUP, there are only 18 patients in the hospital with a COVID-19 infection. So we're way under 100 across all of our hospitals now. It's way down. And our oncology service, which we contracted to our inpatient oncology service to about 40 patients, we have 120 inpatients today. So we are right back up to pre-COVID numbers from an inpatient perspective. And these are patients obviously who don't have COVID infection. But we are prepared to care for those patients in a separate unit.
Great. I also want to follow up on your reassurance that when you use appropriate protective equipment and you have social distancing in your practices, that you can do this safely. And I know that I've talked to our friends and dermatologists in the community, so I know that that's uniformly being practiced, and that instills a lot of confidence in patients. But there was one study from Spain where they modeled the rate of growth of a melanoma and projected that a fifth of melanomas would jump an age-ACC stage by a delay of 1 to 3 months in diagnosis. Emily, you gave the stat that 23 melanomas in the week before COVID lockdown, 2 at the peak of the lockdown, back to 21 today. It is important what you guys are doing in the community to see patients and screen them regularly. You're preventing advanced melanomas, and you're making sure that your patients stay safe. There's one more comment I want to touch on because it's a really important part of the mission at Penn. We are trying to innovate in the melanoma program, new treatments to improve outcomes for patients. And an important part of that is clinical trials. And clinical trials were affected initially by the COVID era because we shifted the focus onto COVID-related research. But the clinical trials are back up and running, and there are some very important ones that the dermatologists will want to know about. Giorgos, particularly yours, where you may have a higher stage melanoma without any active metastases. So maybe you can talk about your clinical trial so people are aware of what's available.
Yeah, thank you, Chris. And Lynn may want to comment too on the whole process of resurgence of the clinical trials. So the one trial that we had predating the COVID pandemic, and now it's up and running again, is for patients with clinical stage 2B and C melanoma. Okay, these are for patients with lesions over 2 millimeters that are ulcerated, or any lesion over 4 millimeters, irrespective of ulceration status. These patients would be candidates to go on the trial, which is basically a neoadjuvant adjuvant pembrolizumab trial. Patients receive a single dose of the pembrolizumab prior to their wide excision and sentinel lymph node biopsy procedure, which is done 3 weeks after that dose, and then they remain on 1 year of adjuvant pembrolizumab. And this trial was really inspired by a prior trial by Thara Mitchell, Alex Huang, and our group, the melanoma group, for patients with clinical stage 3 melanoma, bulky lymph nodes, that received a single dose of pembrolizumab. And in 30% of those patients, when they went to surgery 3 weeks just after a single dose of drug, we had patients with a complete path CR or near path CR. And that actually, that biomarker of path CR correlated with a durable disease control. None of those patients.
Let me clarify, a path CR is pathologic complete response. Just make sure we're.
Yeah, no, thank you. So pathologic complete response. And so that really inspired us to think that maybe we can move this to an earlier stage patients and even see a more profound effect in that population. So that's a trial that we have for patients with clinically localized melanoma. There's another trial that's sort of the next version of the Thara Mitchell's prior clinical stage 3 trial. It's another trial for patients with bulky lymph nodes with clinical stage 3 melanoma who also received neoadjuvant. This is nivolumab, another PD-1 inhibitor. And in that particular trial, if patients do not have a pathologic complete response or near path complete response, they then get switched over to a combination of ipilimumab and nivolumab. And so.
We have just a few minutes, and I really want to emphasize your clinical trial because that is the one that dermatologists are going to encounter the most commonly. A stage 2 patient who has you've done a biopsy of a melanoma of somebody that's got greater than 2 millimeters and ulcerated or greater than 4 millimeters any depth, but no evidence of metastasis. That is a patient that you can offer great help with this clinical trial. So we're really excited about that. That trial is really relevant to a lot of dermatology practices. Lynn, we got about 30 seconds or so if you wanted to sum up the research, and then we'll respect everybody's time and have our information available for people to contact us if they had individual questions.
No, I just agree with what you both said. I think this is the most important trial for our community to know about, and it's the only way to get access to this very effective drug is to enroll on this study. So I think it's great. You know, we do have a number of studies for stage 4, but I think you know that, and you've been sending our patients our way. But these patients we need to see prior to sentinel node. It's a unique patient population, but such a great option.
Great. So thank you guys thanks to the panelists for great insight into managing melanoma during COVID. Thank you to the audience for spending the hour. And we have contact information here on the screen. Please feel free to email or call any of us if you have individual questions about what we discussed, or if you'd like to help with any of your patients. So thanks to everybody, and we'll look forward to collaborating with you in the future.